Welcome to Black Women's Health Podcast. I'm Dr. Rahman, and it's my pleasure to introduce my guest. Her name is Dr. Wyland D. Wilson. Dr. Wilson is currently an associate professor of theological ethics at Duke Divinity School. She earned her PhD in religion, ethics, and society from Emory University. But she is here today. She is here today because she is the author of Womanist Bioethics, Social Justice, Spirituality, and Black Women's Health. Welcome, Dr. Wilson.
Thank you. It is a pleasure to be here with you. I want to start kind of um, in my past, long time ago, right? Kind of like where I was born. And
Yes.
because that'll also help the listeners to understand kind of the impetus behind this book as well. So, so I was born in Florida. I was actually born in South Florida, and my parents moved to North Florida when I was 3 years old. So I actually grew up in the culturally southern part of Florida because South Florida is not, but Northern Florida is. And so I was born about 10 years after the desegregation of hospitals. We often talk about, desegregation within our educational institutions, within, public facilities. But we do not have the conversation that often around our Jim Crow healthcare history. And so with being born in 1973, those stories from my family members and from other members of my broader African American community and church community, there were many stories that were still very fresh for folk about how they suffered in the healthcare system in this country, precisely because hospitals weren't desegregated until around 1964. So, and my father, I really appreciate my father opening up about his experience under segregation, because I know how painful it is to talk about these kinds of things, but
Mm.
he even shared with me in the white waiting room as my grandmother had his hand, it was leading him around the back to the black waiting room. He would look through the glass window. He saw cushioned chairs, carpet on the floors. It was so beautiful, paintings on the wall. It was just
Mhm.
beautiful. Um, and he said by the time he got to the back, as a little boy, he just remembered looking at the dirty floor, unfinished, just chairs thrown in. They weren't even no cushions, like just, folding chairs thrown in there. Nothing on the wall, just an unfinished, place. And so yeah, so it was definitely a stark difference. But also there were just hospitals that did not accept and would not see Black patients at all. And that's a story that goes back even to my birth, my mother's birth, um, where her mom could not be seen at the nearest hospital because they would not even accept Black folks as patients. So yeah, so we look at that history. There's a lot of pain, a lot of death too, right? A lot of folk died because of our Jim Crow healthcare history. Mhm.
Absolutely. And the other point is that wasn't that long ago.
Thank you. Exactly. And that's why I like to start there. Even with my students, I need them to understand during my lifetime, my great grandmother, she was the daughter of enslaved Africans here in the US. And I remember as a child sitting at her feet, listening to her, talk about, her childhood. And so I always try to help people to see that we are not that many generations removed even from slavery in this country.
What does slavery have to do with health.
Ah, yes. Oh, so very much. Particularly, um, I one of the important claims that I make is that slavery is one of the important places where Black suffering was normalized,
Mm.
right? And so this whole normalization of Black folks and suffering in this country started there, and it still has not stopped, right? Because we have literally gone through centuries of health disparities, and health disparities being disproportionately borne by folks of color, particularly African American folk in this country. And it's amazing how with many of these health disparities, there should have been an uproar, right? There should have been protests, but because suffering of Black folk has been normalized, starting there, starting with the enslavement in this country, I do believe that that is why we see what we see when we see this kind of disproportionate burden of health disparities and health inequities. And folk just, it's amazing. Like sometimes we don't even bat an eye
Yeah.
sometimes here in the statistics.
Any care, any medical care that a slave received was not for the slave. It was for the benefit of the slave owner.
That's right.
The slave was his asset, his commodity.
Mm-hmm.
He needed to make sure it was working, that it was functional.
That's right. That use value, right? This use value of things. And
Right.
so
And for women, it was even more so because not only did we have to be workers,
Mhm.
we actually had to be breeders.
Exactly. And it we was and things got worse when the transatlantic slave trade became illegal, right?
Ah,
Because then
yes.
then when slavery kept on going here, and particularly in southern US, the the breeders were really important because then those women, because they weren't able to bring over enslaved Africans, the women had it's just horrible. It was really hard writing that historical piece because women had to they were raped, you know, by the owners and whatnot, because they were breeding more slaves. And so so yeah, that notion of breeding, that history is it's just it's devastating.
Horrible. It's
It's
horrible.
devastating. And one of the things that is really interesting to see with our history is how the institution of slavery, as well as the legal system, as well as the medical system, um, and the religious system, how they all combined, right, to make the slavery as productive as it was, right? And to ensure that it worked and to ensure that it was this lucrative, you know, economic enterprise. And so to me, that is the worst part of looking at our history, is how all of those institutions and systems were very much intertwined, like you were saying with Dr. Marion Sims, right? And how he did medical experimentation on enslaved women, and he was not the only one, right?
Mm,
Other doctors as well, um, performing cesarean sections, because we don't think about the fact that cesarean sections are performed on women now, um, when they are, well, you know, as when we were alive, right? But back in the day, they were not performed on women who were living. They were only performed on women once they had, you know, passed away while trying to give birth. But there were doctors who back then during this experimental medicine on
mm.
enslaved Africans did cesarean sections, C-sections on women who were living. And that was not supposed to be done then. Yeah.
And it doesn't get a lot better after slavery
Mm-mm.
because we went from being an asset for slave owners to a problem.
Exactly. That's right. That's right. And that whole notion of being America's problem, just there was no end to the amount of suffering caused there as well, right? And that's also one of the reasons why it was important for me to write this book and to write it from the perspective of womanist thought, womanist theology, right? Is because within womanism, there is this this in the womanist approach, right? There's a requirement that the most vulnerable among us be the starting point
Hmm.
for an adequate understanding of what justice means in human relations.
What is bioethics?
Oh, yes. Yes. So bioethics, it is the study of ethical questions and dilemmas that arise in health, science, and technology.
Can you give me an example?
Oh, yes, I can. Yes. So bioethics deals with the issues of, say, beginning of life. So a lot of people, will be very familiar with all of the issues around abortion, right?
When does
And
life begin?
when does life begin? That's right. And then issues at the end of life. So there have been, and will continue to be debates about death. When does life end, right? Because the definition of death has changed through the years as well because of the technological, the biomedical, technological innovations. So wherein once you were dead if you just, if you stopped breathing, if your heart stopped, right? Well, now we have ventilators.
Hmm.
So the definition of death has to change, right? And then also bioethics deal with this notion of suffering because you have folk now, so they're being kept alive on a ventilator. Um, but there's this notion of suffering that comes into play as well, right? And so we're able to do so much with our technological innovations in medicine, but it still brings in all of these questions of our moral claim, what claims do we have upon one another, right? So organ transplantation, right?
Hmm.
um all of that, see, like all, so bioethics is it's a fascinating field, right? Because even genetics, looking at, the significance of the human genome, all the so all these questions are so intriguing and they're really fascinating. But I come to bioethics, and I came to bioethics through the rural Southern Black Belt, through an area that was so impoverished that folks, even if they could get to the hospital, because they're in Tuskegee, right? I was working at the Bioethics Center in Tuskegee, Alabama. So even if people could get to a local hospital, really it was regional, they may not have the health insurance to even afford these wonderful, biomedical technologies, right? So a lot of what is talked about in bioethics, a lot of things that are debated in bioethics, if you are impoverished, you don't have access to it anyway, right? So for me, so my coming to bioethics, I came through the reality of health disparities, you
Hmm.
know, the reality of a population, because the Black Belt in this country is known, and it was called that because of the rich, dark soils that once supported uh, the slave economy, right?
Hmm.
And then after slavery, unfortunately, those areas, particularly the rural areas, they were and still are economically stagnant. So there's high poverty, right? High unemployment, right? So these areas, there is still this continuity of devastation from enslavement even till now, in much of what now is still left of this Black belt. So that's how I come to bioethics. So that's why I look at different issues. I'm not so much, as you see in the book, I'm not so much talking about all of the innovations that have gone
Right.
come about.
Are you saying that it's the bioethicist that decides, that makes these decisions?
They make the decisions in conjunction with the physicians. So bioethics has found its home not only in the academy, but within hospitals, right? So I had the utter joy. It was really, really, really a blessing to serve on an ethics committee at a local hospital in Cambridge, Massachusetts, when I was living there. And so what was interesting to see, so on the ethics committee, so what these committees do is, and not all hospitals have them, right? Because one, it takes resources because you have to have someone who will be over the committee, who will convene the meetings and whatnot. But it is a committee that's made up of physicians, whether they be surgeons, primary care, it's made up of nurses, social workers. So kind of you get a lot of folk in the room, and it's made of folks like myself. So I was at the time I was on faculty at Harvard Divinity School teaching, and so I called just to volunteer because I understand the significance of these ethics committees having diversity, right, in perspectives, but diversity ethnically and culturally and all of that. And so it was a joy to go and sit on this committee with different medical professionals because we talked about the dilemmas they face in their everyday, work, right? So some of them would have a patient who was brought into the hospital, and it was a woman, a middle-aged woman, and she clearly had some neurological issues, and the husband who brought her in, very stern, controlling, um, and you could tell she didn't have the freedom, right, the autonomy that she needed. And so the doctors and nurses are trying to figure out, how do we navigate this, right? How and what kind of services do we need to give to support her, because we don't know, is she being abused at home, like, so it's all of these complex issues that an ethics committee helps uh, a physician and other health care professionals to discern. We discuss hard cases and we help to kind of figure these things out. That's right. As well as, so not only with healthcare, and this is why bioethics is a really important field, because bioethicists also affect policy decisions. So the notion of when does life begin and the definition of death and all that. So there are policies around these issues, right? And so this field of bioethics, and that's why this book was really important to write, because I wanted to reach not only healthcare providers, not only chaplains, in hospitals, and pastors and whatnot, but folk who are public health, in the public health field, and folk who are dealing with issues of policy, because that affects the lives of all of us as well. Anytime the syphilis study comes up, I always want to give the full name, because it was the U.S. Public Health Service study of syphilis in the Negro male. Because I think oftentimes people, because we use the shortened version Tuskegee syphilis study, I think people think, oh, it was just something that was done at Tuskegee Institute, but no, it wasn't. It was our federal government, right?
Got
And
you.
usually when I teach that, the students are really shocked because they're like, wait a minute, our
Got
government
you.
did this? And I'm like, yeah. And I was like,
Okay.
it's published in the medical journals,
Okay.
and that's the official name,
Got you.
U.S.
Yes.
Public Health Service, so anyway, but with the field of bioethics, it really was preceded by medical ethics and medical humanities, right? And so it definitely has its lineage in that, but medical ethics really was not sufficient, particularly when you look at all these technological innovations that were coming about, right? And so that's why bioethics was really kind of really important and came on the scene, as you were saying, um, really in the late 20th century, because of the complexity of medicine and of healthcare. Medical ethics is usually, particularly how it started out, it was looking at the patient-doctor relationship, fees, kind of physicians' fees and whatnot. So as medicine began to change from the kind of the lone doctor doing house calls and house visits, when that began to change into now what we have is the medical full-on healthcare institutions, right? And there are research institutions and all of that. That's how bioethics really became very important and really significant, and has embedded itself within healthcare facilities, which for some people is problematic, right? Because if if an important part of bioethics is to help to ensure that the wrongs, such as the syphilis study, right, and all these other kind of biomedical um, studies that were egregious violations of ethics and of human rights, if it came about because of that, folks are really concerned that if the field now is truly deeply embedded in hospitals, and it's usually, of course, on the side of hospital administrators, right? Then folks are concerned saying, well, wait a minute. So who's looking out for the patient's interests?
Mm-hmm.
That's why some people kind of have a problem with the fact that it's really made a big part of its home in healthcare institutions, because folks want to make sure that it is doing what it should be doing, which is looking out for patients.
You started telling us about the experiences of your family of being discriminated against and not being able to receive health care. Can you talk about medicine, how it affected Black doctors, how it affected Black hospitals?
So it's a really fascinating thing when we look at medicine in this country, but particularly medicine and race, right?
Mm-hmm.
Um, because Black people were locked out of the mainstream public health institutions and medical facilities. Because they were locked out, that meant that Black folks turned to places like the Black church, right? And the Black church, of course, just out of necessity, had to do more than care for the souls of people. It had to care for the bodies and the souls. And so there's a really significant legacy. I call it a legacy of care within these Black religious institutions. So some of the first Black hospitals actually were established with the help of Black churches, right? Particularly Black church women and Black club women as well, because the women's movement, the broader women's movement, where Black women were locked out of that, is the reason why we had Black club women. So Black women were so active in making sure that the well-being of Black folk was something that was prioritized. And so Black church women raised a lot of funds, and Black club women raised funds for the creation of Black hospitals, Black nursing schools, because Black folk not only were locked out of the healthcare facilities, but the doctors, Black doctors who were had gone to medical schools, and usually they had to go to a Black medical school because they were locked out of medical schools as well as professional medical organizations. So that's why we have, in addition to have the American Medical Association, we also have the National Medical Association, right? Because Black folks had to create their own institutional structures so that Black doctors could not just have a place to practice medicine on folks who were locked out of the mainstream system, but they also needed the professional training, right?
That sounds like a good thing. We had Black
Yes.
doctors and Black hospitals and Black
Yes.
nurses. We had the Black church. What happened?
One of the things that happened is the standardization of medicine. A lot of folks blame the loss of a lot of our Black hospitals. They blame it on the Flexner report. Because of this report, it was really important. It was seen that what was really important was that we needed standardization in our medical facilities, and we needed to ensure that the doctors had the proper training, and it was just detrimental for Black hospitals because many of the Black hospitals that were established, um, they weren't big institutions. Many of them were smaller institutions. Some of them were run out of a person's home because of this, standardization and the healthcare reform that was going on. A lot of the Black hospitals were shut down. And within the Flexner report, it's very clearly stated that these Black medical facilities were inadequate. That was something that was really important for Black hospitals and the evolution of, our Black hospitals and Black medical schools and whatnot being shut down, because we're down to two now, because we still have Meharry, of course, and Howard. But there were what, hundreds at one time, right? So yeah, it's taken a hit. And it's very interesting. So some people claim that what we need to do to make things better for Black folks in health is to bring back Black hospitals, right? One of the things that is so important to look at is that all of the investment that's needed to establish a medical system and medical institution in the 21st century, unless you have really, you have to have,
Resources.
I mean, so many resources. And
It's
I don't,
interesting.
yeah, and I don't think that that kind of investment is something that our governmental institutions are interested in.
But then you think about the story of the Black midwives in the South
That's right.
who were basically put out of business
Yeah.
because they didn't have the proper certification.
It also makes me think of the whole genetic code versus zip code um, dilemma, right? So when we look at how the the zip code, because some people would say, oh, well, it's, genetics is so important. Oh, it's so significant for health. And, people are talking about personalized medicine and all this that is now, made possible because of genetics. But what's a, 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 a glaring reality for all of us, a sobering reality, is that our zip code is a greater indicator of our overall health and life expectancy than our genetic code. Because the reality is, if you're looking at us genetically as humans, there is it's a minuscule amount that is very different between us, particularly as between white, blacks, and ethnicity and race and all that, right? So what's important is looking at these social factors that doctors don't see during the checkup, right? Such as the distance of someone's home from the closest grocery store, right? Someone who is really dealing with food insecurity, the available green space in someone's neighborhood, or the fact that they cannot walk on their street safely because there are no sidewalk. I grew up in a neighborhood with no sidewalks, right? And very little green space because I was in a predominantly Black neighborhood on the south side of town. And so looking at the fact that these social factors, these social determinants of health are so significant for our well-being, in this country. And so wherein we've come out of segregation that was upheld by our legal system. We've come out of that, but the hard truth is that we are still segregated, particularly if you look, and especially, and it's glaring if you look at the statistics of zip code, race, and health indicators.
When we look at health disparities, a lot of times they will say we see these disparities irrespective of socioeconomic status. So
Yeah.
how do you reconcile that?
Right. And so that's where this notion of racism as root cause comes in, right? Because the field of public health has done an excellent job of actually showing that racism is also a social determinant of health. And it's undeniable, and it's in the scholarship, right? So yes, that is absolutely, absolutely clear, absolutely true, that these disparities and are definitely at the root.
So it's not race,
Mhm.
it's racism that's the problem. What does racism look like? How do you point out a racist act?
Right, right. And so herein lies the dilemma, right? Because now what has happened is that racism, it is so deeply embedded and so much a part of our institutional structure, right? So this notion of structural racism. So the fact that we have so from enslavement, one of the things that happened is that we got a lot of false narratives, right? Because enslavement, in order for that to actually be successful, we really needed narratives to help
Justify.
justify
Yes.
enslaving human beings, right? Like this
Right.
is insane. It's just because it's so
Right.
absurd. It's absurd.
Right.
And so all of these false narratives, right, um, have been swirling in our culture. And one of the things that the Black club women and Black church women were absolutely fighting on every front were the narratives about Black women being hypersexual, Black women being these awful mothers. And, like there were just so many false narratives. The narratives about the angry Black woman and whatnot. And so these narratives have not gone anywhere, right? They are still with us. They morph. So the blatant racism that we saw earlier in our history has now morphed into now implicit bias. And so we don't even realize how much we are continuing to play the old scripts, like the It's when you go and see a play, it's very important. A lot of times people say stick to the script, when the actors are rehearsing, it's like, wait a minute, you're going off script. If you go off script, there's another play, right? And so we have these cultural scripts that we are continuing to live into, and perpetuate these cultural scripts that are deeply, deeply ingrained in us, and it shows up as implicit bias. So a doctor may, it's very interesting, this whole notion of, non-compliant patients, right? um and doctors may very quickly dismiss an African American patient, particularly say an African American elderly woman, um as non-compliant because she, didn't get her prescription filled. Well, if the doctor was clear on what was going on in her life, you would understand this woman is now, she's retired, so she's on fixed income, but she's also now caring for her grandchild, right? So the money that she does get, she has to feed that child, but also she needs to put gas in the car to get over to the pharmacy to get but she also, like, it just sometimes is not possible. And that's one of the things I
Okay,
saw
I'm going to
in
play the
Black folks.
devil's advocate
Sure.
just a bit.
Yes.
Granted, she has all these extenuating circumstances, justifiable reasons, but she's still non-compliant.
Yeah. And I'm not saying, okay, so thank you. So I'm not saying that even without those, circumstances that she would be, oh, she would totally be compliant. But I'm just saying, like, there sometimes there is um the assumption that a patient will not be compliant given,
Yes,
their
yes,
race.
yes.
Mhm.
Actually, I think about two women that have actually been guests on this podcast. One woman told the story. She was at the time a doctorate student and she had gone for some sort of physical. And during the physical, the doctor told her, "Oh, we need to send you for STD testing, testing for sexually transmitted infections." The patient said, or this woman says, she was confused because there was no reason for it, but she was going to go along with the doctor's recommendation because she couldn't think of a reason why not. Didn't have anything to hide. And then they started talking, and the doctor realized that she was, in fact, a PhD student. And when she heard that, she then said, "Oh, you don't need to go get the STD testing."
Mm.
And so this woman tells the story, and I asked her, did she say anything to the doctor in that moment? And she said no. And I'm convinced that this doctor never thought what she did was
Right,
racist.
right, right. No,
Unlike the
that's
patient
good.
who was convinced that this was a racist act. How do you deal with something like that?
So before I answer that, I also want to say, so when I go to lecture to medical students, right? So I did a lecture, I won't say at a university, and some of the medical students were saying, because I was talking about these narratives, right? The significance of narratives that are perpetuate certain stereotypes and whatnot. And so one of the students was saying, "Hey, you know what? Our textbook says that Black people have thicker skin and they experience pain differently." And I said, wait a minute, you mean a textbook in this 21st century is saying that? And she said, yeah. She said, that's one of those narratives, isn't it? I said, yeah, unfortunately. So what's wild about this, right, is that even in the training, we still have some of these, false narratives.
Mm-hmm.
Um,
Mm-hmm.
so getting back to your question,
Absolutely. Absolutely.
yeah, and so getting back to your question, I think about the Centers for Disease Control and Prevention and how they had to begin the campaign, the Hear Her campaign, right? And that campaign was for, particularly, it was targeting the Black maternal health mortality, but just maternal health mortality in general, right? Because there's a broader maternal health mortality in the United States, and then within that, the Black maternal health crisis. So the Hear Her campaign was started by the CDC, particularly because women and Black women, you're going to the hospital, you're letting folks know that I think something's wrong. I know my body, and I just believe there is something wrong. Can you please check this out, or can I come in? Or and we know the stories, right? We know the Serena Williams story, and I do in the book I mentioned various stories of Black women who actually died um, uh, during or immediately after childbirth. And so the CDC campaign is trying to raise the awareness and say to physicians, other healthcare practitioners, but then also families and community members, please listen to women. Listen to women when they tell you that there's something wrong, or they feel like something's wrong in their body, or when they want to come in, they want you to run a test. Listen, because that's how serious this is, right?
Right. Uh, Women deserve to be heard. That's undeniable.
Womanist bioethics is actually a way of responding to the Black women's health crisis in this nation. And it's a way that actually centers the experience and the spirituality of Black women seeking justice in health, science, religion, and the environment. Because as you know, in the book, I also talk about environmental injustice as well. So womanism is so important because it allows us, it gives us the starting point, right? The starting point is Black women, right? And womanism came about because, particularly womanist theology, right? Which is what this book builds on. Womanist theology came about because the broader field of theology, mainstream theology in this country, is very much focused on European and European American male experience, right? And so the voices and the bodies of Black women and Black women's religious experience, Black women's spirituality, has not been centered in mainstream theology or ethics, right? And so womanist theology is making the claim that Black women's lives, Black women's bodies are also a site of divine revelation and power. And therefore, they are deserving of love, of care, right? Of respect. And so that's why womanism is so important to combine with bioethics, right? Because bioethics is the same. It has been centered on European, American male perspectives. So to be able to center Black women's bodies and voices and experiences and spirituality is so significant when we're talking about Black women's health. The starting point is with Black women, but just like with Black women movements throughout our nation's history, the goal is for the liberation and healing and care of all of humanity. So it starts with our experience.
Because we as Black women in this country have a long history of being neglected, deprived, not receiving the type of care we deserve. And
Yes.
the thought is if we can correct that, we should be able to correct that for everybody
Oh,
as
yes.
well.
Oh, yes. Yes, it is so important. And that's one of the most important things that I'm trying to demonstrate in this book, that Black women fare worse than others across almost every health indicator. Um, so therefore we must not just include, right? But we need to center that Black experience and voices in our bioethical discourse and practice. Yes.
Okay, I'm not sure what that looks like. How,
Yes.
how does that look different from what we see today?
What what it looks like for bioethics to do this is within our conversations about, you know, beginning of life, end of life, suffering, all of this. You don't just start with, because one thing that people criticize bioethics about is that it's very philosophical, and so it's kind of the universal human subject that it deals with, not the specific concrete
Mhm.
subject, right? And so that's what I'm arguing, is that we need to look at the concrete lives of women in this country, particularly Black women who are underserved within our healthcare system, right? Um, who are burdened with just lack of access to quality healthcare. Like, look at this experience and center this experience. We need to start there and say, okay, so we know that the lives of these Black women testify to the current state of this healthcare system, but they also interpret and critique it, right?
Mm.
So yeah, so we need to learn from that, and we need to see, okay, what is it that we need to be doing to meet the needs of those who are what I on the underside of the healthcare system, right? One of the things that it definitely looks like is the having representation on ethics committees, which is really important, because myself and there was one other African American on an ethics committee serving at another hospital. And we would always talk about the fact that, my goodness, there's so little representation and diversity on these committees, but
Mm.
yet the problems that they're dealing with, the dilemmas, the ethical dilemmas, usually had at the center of them someone who was a person of color, particularly a Black person or a minoritized individual. So definitely bringing folk in to our spaces where we are making decisions about minoritized populations, and folks who are suffering from health disparities. But it also looks like our healthcare institutions doing some truth telling, right? Talking about the real the reality of there being historical advantages and disadvantages, for different folk who encounter the healthcare system, and how racism has had and has a role in structuring our social determinants of health, and how we also need to have a universal screening for these social determinants of health, right? And what it also looks like is hospitals partnering with social services and community organizations that can help address the needs of women who come in, and their children, and other folk, men in the community, folks who are minoritized, when they come into healthcare systems and have these needs that are beyond what the clinician can control. We need to have collaborative kinds of partnerships already in place, so we then can, help the person get what they need, because they can't get everything from the doctor, right? And we need to include Black women's wisdom. It also looks like us including Black women's moral wisdom, the wisdom of our midwives, the wisdom of our doulas, right? Um, and lastly, of course, listening to Black women. Just that simple. And what I would also hope is that, a lot of times when we do our research studies, including them there, because there are many studies that are done on Black women's health, and you look at how this study is done and you're like, wait a minute, so where did they bring in the Black women from the community? Because these are the folk who they're focusing on in the study. And so it just looks like that notion of including and centering these voices, these perspectives, particularly where these decisions will be made about their lives, which will be affected by our policies and studies. Yeah. One of the things that has been important for me with this book is this womanist approach emphasizes this notion of interdependence and writing of relationships, but proximity and understanding, right? And so what I hope that my book does, I hope that what my book does is shows the significance of us really leaning into proximity. Because a lot of times what happens is folks are making policy decisions. And I mean, we are going about our daily business and making decisions about what happens to the lives of people in our communities. And we have absolutely no proximity to them and no real understanding of their real life experience, right? And so what I am hoping is that people really pick up my caution against these superficial calls to solidarity. And that's why I went through the pains of going through the detail of these stories and our history, because before we can have these calls of unity and solidarity, it is significant that we confront and resist the harm and the violence against vulnerable bodies, right? We need to understand not just ourselves, but ourselves in relation to folks who are different from us on their own terms for their own sake, right? And so that we absolutely lean into the great legacy that we have been given, the legacy of care from, like the Black church and the Black club women, Black church women. We have a legacy that we can build upon of absolutely caring for one another, providing for one another's needs. So for me, my hope is leaning in to what we've already been gifted by our ancestors.